Welcome to Select Communications. Enter your conference code, followed by the pound or hash sign. Thank you. If you are the leader, press star now. You will now be placed into conference. To mute your line, press star 6. To unmute, press pound 6.
I see she's in WebEx, so I'm guessing she's dialing in now.
Hi, this is Brandy. I'm the WebEx host today.
Hi, Brandy. It's Nancy again.
Okay. Hi. Should I make you a panelist as well?
You can. I think the any QIN-QIO presenter, that's going to be Kathy.
Okay. I already passed her the ball.
Awesome.
I don't have to do anything on my end, right?
Yeah.
Okay.
Hi guys, it's Anna. I just wanted to let you know I just logged on.
Hi, Anna.
We're so relieved you're there. The hard part's over.
Such a happy, upbeat group. I love it. So I think we're all on. I'm just going to wait for Lynn real quick. Lynn, are you on?
I'm on.
You're here. Good. Everyone's here. So punctual. Look at this. 10:45. I love it.
They're very compliant on Butler.
I love it. I love it. You're my type of people. So what I'm going to do now before people are going to start kind of coming in, I'm going to go ahead and mute all of the lines. Hopefully they stay muted. I think as Lynn sent out in her little logistics notes, which I think are great. So we won't be able to hear anyone, but they'll be able to hear us. So if you're kind of talking amongst yourselves, you might want to put your phone on mute. Once we get about 5 up, I'm going to start kind of coming in every couple of minutes, just greeting people, letting them know that we're here, and letting them know like we're going to be starting soon. Okay?
Nancy, do you have your cell phone to check? I didn't bring that with me.
Let me give it to you.
Okay.
Are you ready? It's 860 416 6954.
Okay, so there's nothing else. Like right now, they're looking at the screen. Is that
Yep.
how they see it?
That's what I see too. So
All I'm going to control is the advancing the slide right on the arrow.
yeah. So why don't you just do one real quick to make sure it's working okay? I'm sure it is. Perfect. Perfect. Okay.
And Lynn,
So
if you have anything, you're going to text me, right?
Exactly.
Okay, got my phone out. Okay, going on mute then.
okay. All right. So I'm going to mute all the lines, but then all the speakers need to hit pound 6 to unmute your line. Okay. So hold on. I'm going to mute everything.
The leader has muted your line. To unmute your line, press pound 6.
Okay. Can you guys hear me?
Unmuted.
I can hear you. Can everyone hear me?
Is that Anna?
Yeah.
Sound great. Perfect.
Okay.
Kathy, Maureen, and everyone else, are you there too? Your phone might be on mute. You want to hit pound 6.
Eric now?
Okay, we can hear you now.
Okay. So pound 6 unmutes us. Okay.
So just just keep it like that. Just mute your phone. Just push the mute button on your phone.
Oh, put the mute on?
Yes.
Okay.
Okay. All right. So let's just sit tight. People are coming in, and I'll start greeting people in a couple of minutes. Okay. Good morning, everyone. This is Nancy Kelly from the New England QIN-QIO. Thank you all for joining our WebEx today. Please stand by. We're going to start in about 5 minutes. Thank you.
Hi, John. How you doing? Okay. Carolyn Spike. Yep.
Can I just put this on speaker, Jerry? I think so. Will it come through phone or just that?
I've never done it.
I should have left this one here. We were heard for my speakers. We're not muted.
The leader has unmuted your line. The leader has muted your line. To unmute your line, press #6. Unmuted.
Good morning, everyone. Thank you for joining our webinar. We're going to get started in just a couple minutes. Thank you. Good morning, everyone, and welcome to our Care Transitions webinar session today. It's 11 o'clock, so I think we're ready to get started. At this time, I'd like to turn over to Kathy Calandra to officially begin the webinar. Kathy? Hi, Kathy, if you're ready, we're ready to begin.
Good morning, everyone. Sorry for the delay. This is Kathy. Good morning, everyone. This is Kathy Calandra from the Rhode Island Care Transitions Lead from the New England Quality Innovation Network, Quality Improvement Organization. Thanks for joining us for today's webinar. Today, we are here at Butler Hospital. The title of our program is Bridging the Divide. Butler is going to speak to the Inpatient Psychiatric Hospital's approach to improving transitions of care. Before we get started, just a quick review of some housekeeping items. The call will be recorded for training purposes. We will make the recorded presentation available within a few business days after the webinar on our website. The phone lines will be on mute for the duration of the presentation. We are going to take questions at the end, and I'll provide you with some instructions on how to ask questions at that time. Although the lines will be muted, we want you to actively participate in the session. You'll have an opportunity to weigh in via chat, which I'll talk about in just a minute. My colleague, Gail Colden, who's our Vermont Care Transitions Lead, she'll be monitoring and responding to chat during the session. We'd love to hear more about your efforts and how we might best support you going forward. So just a word about our objectives for today. Providers across the continuum are exploring opportunities to enhance care transitions and reduce unplanned readmissions. Although much has been done, a significant opportunity still exists for patients with behavioral health conditions who are most vulnerable for forced transitions. Today, we hope you'll learn how Butler Hospital, an inpatient psychiatric facility, is bridging the divide to improve transitions of care for their patients. So connect with us on chat. During the virtual learning sessions, it's very important for us to connect with each other. Please use our chat feature. You'll see it at the top right-hand corner. Let us know how you are improving transitions of care for your patients and about behavioral health conditions. Use the tools throughout the presentation if you like to note your questions, to share insights, and provide some feedback. You can type in your comments or your questions. And if you just remember to choose all participants in the drop-down, we'll be monitoring your comments, weighing in, and sharing highlights at the end of the session when we open up the line for discussion. So I'd like to introduce today's speakers. We're very glad to have four colleagues from Butler Hospital joining us today. Diane Ferreira is the Director of Care Management and Social Services at Butler Hospital. She's a graduate of Rhode Island College and Salve Regina University with over 27 years of psychiatric nursing experience in both inpatient and the home care setting. She also has 20 years of experience in utilization management and care management. Ms. Ferreira is newly appointed as the co-chair of the Butler Hospital Transitions of Care Committee. Dr. Anna Fulton is Chief of Geriatrics for Care New England and the Chief of Internal Medicine at Butler Hospital. After graduating from George Washington University School of Medicine, Dr. Fulton completed a residency in internal medicine, followed by Chief Residency and Geriatric Fellowship, all at Brown University. She joined the faculty at Brown University in 2006 and currently holds associate professorships in medicine and in psychiatry and human behavior. A major focus of her clinical and academic work is on improving transitions of care for persons with cognitive impairment or chronic mental illness. Dr. Fulton established and co-chairs the Transitions of Care Committee, which you will hear about today. Dr. Lisa Shea is a medical director at Butler Hospital and oversees quality, regulation, and risk management. She sits on the board of the National Association of Psychiatric Healthcare Systems and is a member of its quality committee. Dr. Shea is a member of the National Quality Forum's Behavioral Health Steering Committee and assumes technical expert panels that advise CMS regarding behavioral health quality measures. She is a distinguished fellow of the American Psychiatric Association and holds the appointment of Clinical Associate Professor in the Department of Psychiatry and Human Behavior at the Alfred School of Medicine. And finally, Carolyn Walsh is the Social Services System Administrator at Butler Hospital. She is an active member of their Cultural Diversity, Utilization Review, and Transitions of Care Committee. A significant part of Carolyn's role is focused on helping to safely transition patients back into the community. Ms. Walsh earned her master's in social work from Boston College. So at this time, I'd like to turn it over to Dr. Anna Fulton. Anna?
Great. Thank you, Kathy. We are very excited to be here with everyone today to share our work and to hear about how you all are tackling this topic. So briefly, just for some housekeeping items, you've seen our disclosures. Myself and Dr. Shea had a couple of disclosures, none of which are related to what we're discussing today. We're going to spend some time, as Kathy already alluded to, talking about the evidence based around transitions of care in particularly the behavioral health population. We're going to share some of the lessons learned from our experience here at Butler Hospital and hopefully leave you with some strategies that might help you at your sites and your health systems. So we'll start with a quick review of the landscape of evidence. Next slide, please. So the background, briefly, is just to talk about the reasons why we focus on transitional care, which I think many of you are very familiar with. We know that good transitions of care can help reduce adverse events, can improve patient satisfaction, and even reduce healthcare costs. For our team, we really spent a great deal of time focusing on the population of older adults with cognitive impairment and in adults with psychiatric illness or substance abuse. So if you look at this slide here, it really refers to a landmark paper that really started the strong evidence base for transitions of care work. This article was published by Jenks and his team in the New England Journal back in 2009. What was interesting, as you'll see on the next slide, is that even in this early work, they began to see that for Medicare rehospitalization, you can see, one slide back please, that psychosis was the fourth most common reason for Medicare readmissions. This trend is notable in the Medicare population, but is even more prominent when you look at Medicaid or dual-eligible populations. So here you see this is a systematic review. This is one of the very first articles published around transition interventions, really looking at mental health populations. And these authors found that there really wasn't a great deal of evidence that highlighted what was a successful intervention for a behavioral health population. And they started one of the many trends to really identify specific interventions for this group. On the next slide, you'll see another systematic review published by Vigod in 2013. And this one looked at 15 different studies which looked at interventions specifically in the behavioral health population. They were able to find 7 of those studies as having a significantly positive impact on readmission rates. And they highlighted what some of those effective intervention components are. We'll talk more about some of these specific interventions. The 3 that are underlined are things that we have incorporated into some of our pilot programs. So we'll talk in more detail soon. In May of 2015, AHRQ published a lengthy brief around this topic, and they really brought it to the forefront as needing more attention and not just an application of successful interventions in the acute care population, but a targeted effort around specific interventions for this population. You can see they highlighted the scope of the issue. This slide shows you the top 10 most common reasons for readmission at 30 days in the Medicaid population, you can see that the top 1, 2, 5, and 10 reasons are all specifically related to behavioral health diagnoses and not medical reasons for readmission. They highlighted the evidence well in this AHRQ brief, so it's really worth taking a look at. They noted that unlike the acute care medical populations coming in for congestive heart failure or pneumonia, readmission rate in this population did not correspond well to length of stay. And really, they recommended that we needed to focus more on measures of well-being and daily functioning to predict discharge readiness as well as to predict risk of readmission. They also highlighted that really the only successful intervention in the community is the assertive community treatment program, which again we'll spend some time talking about in more detail when we show you what we've done. So here you see we're going to spend just a few moments telling you about our Transitions Committee and its history and formation. On the next slide, you'll see that this really began, for me personally, in 2006 as a geriatric fellow. This became something that I really developed an interest in with my care of dementia patients. When I joined the Butler Hospital team in 2008, working on their geriatric psychiatry unit, this led to some natural collaborations between myself and the geriatric psychiatry and social work colleagues on that unit. We formed an internal working group and then began to collaborate with health-centric advisors, really looking to how we could shape the work internally as well as across the state. We've had several people join the Health-Centric Advisors Community Coalition for both Providence and Kent counties in Rhode Island. And then we spurred our own community work by forming our own Transitions of Care Committee back in 2012 because we realized that we had a unique population which really needed our own committee work to form some successful interventions. So on the next slide, you'll see the composition. We really focused on developing a multidisciplinary group that represented all departments internally at Butler Hospital. We had psychiatry represented, geriatrics, we had quality, occupational therapy, social work, and care management, as well as our quality colleagues and our performance improvement colleagues. We began focused internally and then began to expand over time over the first year or so to include colleagues throughout our healthcare system, which is Care New England Health System. Then we added some payers because we realized that to really make effective change and to be innovative, we needed some of the payers at the table. We've also brought in state agencies and Medicaid, and this is what forms our regular monthly Transitions Committee group. On the next slide, you'll see a slide that I know nobody can really read, but I just wanted to show you the breadth of the membership. This is now our community outreach group, which meets on a quarterly basis. In 2015, we expanded to include all agencies, community mental health centers, and some providers at other health systems and other hospitals so that we all come together and really have a statewide perspective on what the issues are for this very high-risk population. We modeled it after the Health-Centric Advisors Community Transitions Coalition, and we now have over 40 participants that represent approximately 20 different organizations and groups. And we meet quarterly to talk about this important issue. So here I just listed some of the projects we've completed since we started in 2012. I won't spend a lot of time here because we have a lot to share, but I just wanted to focus on a couple of the important ones. We spent a great deal of time, particularly in our first year, really streamlining information and packets provided for any internal or external transfers to other hospitals and upon discharge to make sure that we had the appropriate information there. The second item there, RN to RN form, this was an example of a really successful intervention. The geriatric unit at Butler Hospital had a one-page form that they Xeroxed in blue every time they had to transfer a geriatric patient to an emergency room for an acute medical event. This became known as the nurse-to-nurse communication form. And when we did some ER staffing outreach meetings, the ER staff told us they really loved that form because it had really helpful information. And they kept saying, why don't you send that with every patient? We realized that the nurses on the geriatric unit had piloted this themselves to help themselves do this. We ended up making this a streamlined part of our packet so that it went with all of our patients, and that was one of our first successes. We did a lot of work to understand our own hospital system, our own patient populations, to really know where we focused. So we did a lot of data deep dives to understand our patients. We asked them themselves what their challenges were, and we tried to revise our psychosocial assessments to make sure we captured the right information at admission, to make sure we knew what this patient's particular challenges were going to be. I already mentioned a lot of the collaborations with our members on the committee, and we've done in-depth research projects to understand what works and doesn't work with our population. Two of the ones that I'll just mention briefly was a patient survey project where we used Eric Coleman's questions from his care transitions measures on our patient populations to understand what their challenges were and how they felt at previous discharge. We also did a peer navigator project to see how that helped our patient population. And those projects have informed some of the pilots that we have to tell you about later today in our slides. So the community outreach really was key in how we changed the scope of our work. So we used the coalition model that health-centric advisors have used, as I already mentioned, to really grow our committee and to take it to the next level. Those collaborations have been very successful and have led to some changes in how we communicate. One example of a successful intervention was the discharge summary project that actually sort of happened naturally. The very first quarterly outreach meeting, one of the community mental health centers told us that they felt they never had discharge summaries at the time of follow-up for any patients coming out of Butler Hospital. Our medical records lead contacted that community mental health center's medical records department, and they began a real-time quality improvement project. Every time a patient showed up for follow-up at that mental health center, if the provider did not have a discharge summary at hand, they would call our medical records lead directly, and she would find out what happened. We ended up finding that the providers were looking for a faxed discharge summary, but in reality, we were sending them electronically right into their medical record. She was able to solve the issues, and we've never had complaints again. It also led to a wonderful development of our next quarterly outreach meeting where other community mental health centers requested electronic access, and we're now sending into their medical records as well. We've also spent some time with our legal representatives at both our state level and our local level to talk about communication issues. Something that often came up was worries about HIPAA and 42 CFR, and many of our own internal social workers and care managers weren't sure when they could communicate, and outside community mental health centers weren't sure when they could communicate with us. For instance, could they tell us that our patient did not keep their follow-up appointment upon discharge? So those communications at our transitions committee level have really helped us improve communication in real time when patients are sitting in our hospital or sitting in their follow-up areas. So we wanted to talk to you a little bit about our readmission rates, just so that you could understand some of the work we've done and some of the challenges. So if you look at the next slide, this is an overview of our 30-day readmission rates since fiscal year 2010 to 11. The committee, as I already mentioned, started in 2012, and we're happy to see a downward trend since then. Just for those of you who aren't familiar with our system, there's two graphs there. The first is the blue one, which represents the Butler Hospital unit. The red bars represent our Kent unit. That unit is on the campus. It's just like every other unit in the hospital. However, it's licensed to Kent Hospital in Warwick, which is our acute care facility. The reason for this is secondary to the IMD, or Institute for Mental Health Disease Organization Exclusion in Medicaid. So it just requires payment stream, needs a different license. The only difference in the patient care population is that they tend to be more medically and psychiatrically complex. So they tend to have a higher readmission rate, as you can see here in the red bars. But we're pleased with the overall downward trend over time for both of those units. On the next slide, you'll see some deeper dive into our data. So 2014 to 2015. Our rates for the whole hospital were about 16%, which we're happy has been a gradual downtrend, as you can see. And then the Kent Hospital unit ended last year at 20.7%. Again, a slight decrease over time. When we looked at diagnoses, our top reasons for readmission by diagnosis tend to be consistent with the literature otherwise. substance abuse disorders, bipolar disorders, depressive disorders, and the schizophrenia groups are the highest and most common reasons for behavioral health readmission. On the next slide, you'll see where we are to date. We're pleased that the Butler Hospital units are around 13.9%. Our Kent Hospital unit is now down to 19.4%. One of the challenges that we've been facing since we started this work is the lack of benchmarking or really a clear evidence base on what a good readmission rate is in this population. These are, as you know, chronic, relapsing, and remitting diseases, and it's very hard to know what was a preventable readmission. We're still working on this, and we're still learning more. We are now part of a quality network that gives you blinded data for lots of different measures, but they did give us a readmission rate of what they described as a close, local, similar organization, and that organization was around 10%. So that's the number we're shooting for. So I'm going to stop here and hand it over to my colleague Diane Ferreira to tell you a little bit more about our specific work.
Thank you, Dr. Fulton. We have taken a number of steps to understand and work towards reducing unnecessary readmissions. We've placed data entry fields in our psychosocial assessment of our electronic health records with categories for reason for readmissions beginning in FY15. We are piloting a rounding template with the social service clinicians use in morning rounds. At the same time in January, we also instituted complex care rounds where an interdisciplinary team meets to review cases with frequent readmissions and transition barriers. The group that meets is the attending psychiatrist, the social service clinician on the case, the nurse manager of the unit, the CMO, the CNO, Carolyn, Walsh, and myself, and various other disciplines ad hoc as needed. In these rounds, the case is reviewed and recommendations are made, and the cases follow closely. Our UR committee has been meeting monthly and now meets twice a month, and we review a dashboard that also looks at readmissions. Also in our UR committee, we get updates on the complex care round cases. We're looking at embedding a readmission assessment scoring tool as well as a screening tool for two programs that we will be talking about later in the psychosocial assessment. We have shifted some social service clinician hours to the weekend to address transition issues. So the morning round template. The social service clinician helps to facilitate morning rounds by using this template. In particular, we are focusing on whether this is a readmission within 30 days and what we need to do differently to improve patient outcomes and reduce the likelihood of another readmission. We are focused on reducing barriers, working with the patient's primary support system, and improving transition plans. This is a draft of the readmission assessment scoring tool adapted with permission from Cambridge Health Alliance. We also use this adapted tool in a peer navigator pilot that Dr. Fulton mentioned earlier. Our plan is to embed this in the psychosocial assessment, which would produce a score which would assist us in determining whether a patient was more likely to readmit within 30 days. Based on a score of 14 or higher, the patient would be considered high risk for readmission, and we would be working on we are currently working on an algorithm based on the patient's payer source, community provider availability, and eligible programs to get patients into transition services within 24 to 48 hours post-discharge. This is the data from the psychosocial assessment on readmission factors. The responses are based on the patient's perspective. As you can see, the top categories for requiring readmission relate to worsening or exacerbation of symptoms, relapse and inability to maintain sobriety, and non-adherence to medication and follow-up care. Homelessness also plays a significant factor in readmission. In FY16, this is October through May 2016 data, the same top 5 categories mentioned in FY15 continue to trend in the same way. We're looking at this data to make improvements on how we work with patients. Now, Carolyn Walsh is going to talk with you about the Health Path program.
Thank you, Diane.
In 2013, our health system, Care New England, and Blue Cross Blue Shield of Rhode Island came together to form a strategic partnership with a commitment to create a more effective healthcare delivery system and to advance the triple aim of improving the patient's experience of care, improving the health of the population, and reducing healthcare costs. The behavioral health was the first initiative to be rolled out, and it started as a 2-year pilot, which was named Health Path. Common interests were to improve behavioral health treatment available to members, to recognize the gaps in the outpatient care, to redesign traditional commercial health insurance benefits to be more assured of coverage across the continuum, to share the risk, and also to take a long view by measuring outcomes in terms of quality of life rather than per episode. So Health Path was the first health home program for Blue Cross Blue Shield of Rhode Island commercially insured adults and Medicare Advantage adults. The clinical approach is based on the assertiveness community treatment model, which is really integrated behavioral health services, which include counseling, psychiatry, care coordination, medication management, connections to primary care and wellness programs, as well as vocational support and case management. The team was developed to offer these continuum of behavioral health services to patients who required more than traditional outpatient therapy and medication management. These wraparound services were just historically available to the Medicaid population, as most traditional commercial benefits did not reimburse for case management, peer recovery, and other costs associated with the high coordination of care. Health Path is a bundled monthly payment, so there was innovation also on the financial side. Health Path receives a set monthly fee for each patient enrolled, and in addition, the patient pays one copay per month, not to exceed $40. So we looked at concern if the patient received many outpatient services during the month, what would their copay be? And we did not want that to be a barrier to them receiving the wraparound services that we felt were required to help maintain their health. So as I mentioned, the model of care was based on ACT. It's very team-based treatment, multidisciplinary, flexible, and available 24/7. The coordination of care is very high, and for example, we have been funded through the partnership to have a dedicated social worker at Butler who handles all readmissions. She coordinates care between the Health Path team and the inpatient team, and that also includes a telephone conference 2 times a week with the program manager of Health Path to review both the clinical needs and medical necessities for any Health Path patients who have been readmitted to the hospital. Some of our outcome measures are based on DLA 20 score, which looks at 20 areas of functioning, areas such as health, housing, safety, managing time, coping, problem solving, hygiene, nutrition, relationships. And so there has been an overall 84% improvement in patient functioning from when they entered the program. We've seen some reduction in the overall behavioral health cost spend. We have seen some increase in the medical spending on the medical side, which we are attributing to a higher coordination of care, getting people in to see their primary care physicians and addressing their physical health. And
The results are trending very positively with a slight decrease in the average length of stay for people who are in the program, a lowering of a readmission rate compared to patients that are not in the program. And we're looking forward to continuing to get data on the program so we can continue with making innovative improvements. Now I'm going to ask Diane Ferreira to take over and talk about our ACO.
Thank you, Carolyn. The Care New England Accountable Care Organization is Integra Community Care Network, LLC. The Integra Behavioral Health Home Team is located on Butler Hospital grounds, and the program began mid-February of this year. It is run by the Providence Center, which is a local community mental health center which is part of Care New England. Prescribing is done by Butler Hospital staff, and the health home team works with the ACO patients in the Medicare Shared Savings Program and the Accountable Entity Program. The program provides services much like Health Pass, with complete wraparound services as you see listed on the slide. We receive a daily list indicating which of our inpatient, partial hospital, and outpatient patients are eligible for the health home team. The social service clinician does the screening tool for the program and makes the referral to the liaison for the program. The handoff is then seamless, and the health home team meets with the patient while the patient is still with us in services. The referral number for active patients is now 53 patients, and we have 8 referrals pending. Now Dr. Fulton is going to speak with you about the Integra Chronic Care Management Team, which is an arm of the ACO. Thanks.
Thanks, Diane. So this Integra Chronic Care Management Team is a program focused on high-risk patients, most of whom have advanced illness. The team includes nurse care managers, social workers, nurse practitioners, and resource specialists who really act as an extension of the primary care office to augment the care provided by that primary care doctor and his and her staff. The nurse practitioner visits, because they have prescribing power, allow us to avoid hospitalizations and readmissions by bringing care into the home. They've done things such as bring in LICSW doses for congestive heart failure exacerbations or prescribe antibiotics after hours for patients who have basic infections that can be treated in the home. The team has twice-weekly interdisciplinary case conferences where we review active patients and all new patients. We run them by either a palliative care physician or a geriatrician who runs the team meetings. We focus on addressing issues such as polypharmacy, symptom management, or advanced care planning. Our goal for these patients is to really understand their goals of care and provide care that's focused on that. Here I wanted to spend some time sharing a patient story with you that we consider as a prime example of the success of these two programs. This patient is a 65-year-old male with a complex medical and behavioral health history. He had chronic hepatitis C, cirrhosis, congestive heart failure, chronic obstructive pulmonary disease, and had a chronic history of pain and depression secondary to chronic pain. He had a history of opioid abuse and illicit substance use. At the time of his enrollment into these two team programs, he had had 8 episodes of care at Butler Hospital and several other medical admissions in the 2 years prior to his presentation. During his last admission at Butler Hospital, he was referred and enrolled in both the Integra Health Home Team and the Integra Chronic Care Management Team. The two teams coordinated well together and met at the Interdisciplinary Case Conference to discuss care for both sides. He received both behavioral health and medical support with nurse care managers, social workers, and an assigned nurse practitioner. As you can see on the next slide, he was discharged last in March of 2016, and since then has not had any further either emergency room or Butler Hospital patient assessment service episodes. He continues to meet with a social worker in the home, has an assigned nurse care manager, and a nurse practitioner who can jump in when acute issues arise. Secondary to the resources provided by the ACO, we were able to give him transportation, which had been a major barrier for him to reach his primary care doctor, as well as some substance abuse support. He's now had multiple visits to his PCP and sees his Suboxone provider regularly. So here I'm going to hand it over to Dr. Shea to talk to you about how quality measures really help us drive our changes.
Thank you, Dr. Fulton. Patient stories are very helpful as they let us know we are on the right track. But as you have heard from my colleagues, the key to progress in moving forward is using data to drive innovation and to ensure we are producing the intended outcomes for the population under our care. Beginning in fiscal year 14, as mandated in the Affordable Care Act, CMS has promulgated publicly reported measures for inpatient psychiatric facilities. New measures have been added each year, with the most recent focusing on successful transitions of care. The transition record measure requires 21 essential elements of information to be transmitted to the next provider within 24 hours of discharge. The 30-day readmission measure looks at all readmissions, whether for a physical or behavioral health issue. We also have contracts with our commercial payers that focus on transitions of care in a pay-for-performance construct, including the two measures already referenced, as well as ensuring patients get to follow up following an inpatient admission. Internally, we have process measures on our quality dashboard that we feel are also essential elements of ensuring a smooth transition, including encouraging and assisting our patients with enrolling in the Rhode Island Health Information Exchange. This is a population that has historically been underrepresented. We also link up patients with a primary care provider to ensure that their total health needs are addressed. CMS is already developing new measures. Possible areas that will be addressed also focus on processes associated with seamless transitions of care, including medication reconciliation and examining claims data to see if patients fill a prescription for their medication following discharge. But ultimately, we do need to focus on outcomes such as quality of life. We also anticipate that there will be a move toward value-based purchasing in behavioral health, consistent with the triple aim of providing high-quality care in a cost-effective manner. With all of the progress being made, there are challenges that still need to be addressed. There is a subset of patients with complex psychiatric and developmental needs who wind up with prolonged inpatient hospitalizations due to lack of community resources such as group homes and transitional programs. We also face shortages of providers who are able to provide medication-assisted therapies for individuals struggling with substance use disorders, as well as those who treat specialized populations, namely geriatric and child and adolescent. Needless barriers exist when it comes for patients being discharged from the hospital to obtain needed medications without a prior authorization. For example, individuals stabilized on Suboxone experience a several-day delay of being able to get this medication once they're discharged, which significantly increases the probability of relapse. It is also very difficult for many of our patients to be able to make it to their follow-up appointments due to a statewide lack of public transportation. Additionally, there are plans in our state to begin to charge disabled individuals to ride the bus. We also need to focus on assisting our colleagues in primary care to be better able to recognize and refer individuals for treatment. We know that providers are reluctant to screen and find problems that they are not able to address or know who to contact for help. Our next action items include adding patient and family members to our Transitions of Care Committee, as their voice is essential as we continue our work. And we will continue to work on coordinating home-based services, behavioral health services, and primary care to provide seamless treatment. In summary, we have learned that it is essential to involve and collaborate with community partners. Communication must be ongoing, particularly around access, and we must be data-driven and continuously strive to improve. Here are some references that might be of use to you. And thank you so much for your attention. We really look forward to your questions. please feel free to reach out to any of us using the contact information provided on this slide.
Okay. Thanks to all of our speakers today. It looks like we have a good 20 minutes for questions. Nancy, could you please remind participants how to unmute their lines and to ask questions? And then Gail, we'll start with you if you can read some of the questions in chat for us.
Sure. So if anyone has a question they'd like to ask over the phone, please press #6 to unmute your line and ask your question.
Hi, this is Gail, your moderator for chat, and we do have some questions, and the first one was from Catherine Gregorian. She would like you to say more about what was added to the psychosocial assessment and what specific questions did you find target the patient's challenges upon discharge?
So specifically on the psychosocial assessment, we added a drop-down menu around the types of things that we know usually can cause patients to readmit, like do they have transportation? Was that an issue? Did they take their meds post-discharge? Did they get their meds filled? Was there relapse involved? Did they keep their follow-up appointments? And we also have in sort of other category for narrative, and that data is collected and put together. And again, that is the patient's perspective on why they feel they needed to come back to the hospital.
Thank you. Our next question is from Mary Catherine Purdy. Is your readmission data based on internal data or external from payers? Does it include readmission to other inpatient care providers in your area?
This is Lisa. What we did show you is internal data, and that is a very excellent question. With our partnership with Blue Cross, we are able to get all-cause readmission data from them, and our most recent numbers is about 13% for that population, which we attribute to the success of the Health Path program. We also are able to get data from our Medicare patients once a year through the PEPR report in terms of an all-cause readmission.
Thank you. Our next question comes from John Korzenowski, and it's, what are your thoughts on using atypical, long-acting injectable medication to further reduce your 30-day readmission rate?
So that also is something that has been shown to reduce readmission rates, and we do, now that patients have the ability to have wraparound services, including nursing, this makes it a lot easier for people to be on long-term injectable medications, where before patients with private insurance, this would serve as a barrier because there was really not an easy way for them to be able to get that injection.
Yes, this is Carolyn. I wanted to agree with what Dr. Shea said. In the past, unless a patient was going to a community mental health center, they would not be able to continue an injectable or a medication like Clozaril because traditionally outpatient providers are unequipped to do that. But I wanted to stress that with the Health Path program, when it was being developed, the Providence Center became part of our New England health system. They run the Health Path program through their subsidiary Continuum, and they are able to continue injectables. They are able to continue Clozaril medication, so it's been very helpful.
And I would add that that's the same for the health home team as well.
Thank you. That's great information to know. From Clifford May, he would like to know questions about the size and volume of your facility, how many beds, and the number of discharges per year. Also, will your ACO qualify as a MACRA APM?
So this is Lisa. We have about 100, including our tent unit, about 180 inpatient beds. We usually run full. Also, we do have a regular ACO, and we are now applying to be a next generation ACO. We also have a robust partial hospitalization program, which has about 80 patients a day.
Thank you. I'm just scrolling down to see what else we have. Our slides, if you look at the top of the chat, will be available on our website. And there's a question about this webinar being recorded. That will also be available on our website. And Nancy Kelly, correct me if I'm incorrect. We have a question here from Grace Bolano. Do you find that you have less readmits if patients attend a PHP program?
Yes, somewhat we do, and there was a study that generally showed that. So partial hospitalization does tend to help reduce the readmission slightly. I don't know offhand by how much. And this is Carolyn. One of the areas we're looking to develop with referral sources in the community is to also use partial hospital level of care as a step-up program from outpatient, in addition to it being a step down. But I think we have some work to do there, and having community providers refer to the partial as an option instead of hospitalization, if at all possible.
The other thing that, this is Diane, the other thing that I would note is that from some of that data that we have looked at around relapse and reasons why patients readmit, we started an ambulatory detox program back in October because we saw that as a need, since not everybody needs to come inpatient for withdrawal management. And we've seen some real success with that. And we've also worked with the peer recovery coach system through the Providence Center, where they're reaching out to the EDs whenever there's a patient coming through the EDs who may on substances or are looking for detox. So we have a very tight network to get our patients into services.
Thank you. Clifford Moy also has a question concerning the dual eligible population. How difficult is it to find non-public community providers, and how have you engaged these providers? I'd just also like to take a moment to remind people they can also call in. If Nancy will remind people how they can do that. Thank you.
Sure. Just a quick reminder, if you'd like to, after this question, if you'd like to ask another question, it's #6 to unmute your phone.
This is Diane. So in regards to the dual eligible patients, because the Providence Mental Health Center, which is one of the major mental health centers in the state, is partnered with us and is in fact part of Care New England, we have very close collaboration. So getting services for dual eligibles is really quite a smooth process. In addition, a lot of the dual eligibles are in our accountable care organizations, so we can enroll them in the ACO health home team, which again, all of those, are an assertive community treatment model, which I believe Anna referred to early in the slides around some work done by AHRQ that indicates, ACT teams really make a significant difference with keeping people out of the hospital.
Thank you. I do not see any more questions in chat. If you care to call in, please do so.
And once again, to ask a question, just hit #6 on your telephone keypad.
I do have a question for our panel. What are some of the lessons learned on communicating the different types of programs and who's eligible for what to the providers and doctors so they can keep track?
Anna, do you want to take a shot at that one?
Sure. So that has been something that we are continuing to work on. We now have several different pilots, and the referring physicians and providers have to know sort of which bucket the patient belongs to. So we've done a lot of outreach to primary care physicians. We've done outreach to our inpatient psychiatrists to try to sort of educate them on who could be eligible for certain programs. We're also working with our information systems colleagues on finding ways to identify patients through our electronic medical record and through our physician order entry system so that when people are in the charts, they can see it on the banners at the top of the chart who is an Integra ACO patient or who might be eligible for certain Blue Cross programs. So I think we're trying to hit it from multiple angles. I think the other thing that has been super helpful is something that Carolyn and Diane have really been working on, which is making sure that our colleagues in social work and care management know all the different pilots and all the different programs, and they've put together flowcharts to sort of guide people in that discharge process onto what programs someone might be eligible for, and that's been very helpful as well.
Thank you, Anna. Are there also challenges collaborating with outside agencies around competition? Did you see any of that? Are there opposing organizations? Have you had to navigate that at all?
So this is Anna. I'll take a stab at that one as well. I think those issues are sort of always something that we tread carefully with. I think what has been really helpful, at least in the state of Rhode Island, and I'm sure other states have noticed the same, is that there's always enough patients to go around, so to speak, and there's always enough business. And I think especially with the changes in healthcare with value-based purchasing and the accountable care movement, everyone's realizing that it behooves everyone else to sort of collaborate because we're always going to be taking care of each other's patients in certain settings, and sharing information helps everyone in the end. I think the health-centric advisors, community coalitions being around in the last few years has also gotten everyone out of the competing health system mindset and put everyone more in the comfort level and just getting into the habit of getting around the same table and thinking collectively around what we can do to really improve the care for our patients across the state. So I think you guys really helped set the trend whenever you started this coalition, and that has continued, which has been really helpful.
So I'll say thank you. Not all me. Nancy, I don't know if you want to remind them one more time. We do have about 6 minutes left. We're scheduled until 12. If you'd like to ask a question, jump in, and chat is still open. Gail, I don't know if you've had any other activity in there.
No, there has been no other activity in chat, but I'm sure one of the questions might be, would you be willing to share your template?
Would you be willing to share your template?
Sure. There were quite a few that were mentioned, but in the beginning, I think there was mention of when you're looking at risk of readmission.
Yes, that template is actually in the slide deck. That's the readmission assessment scoring tool.
Yes.
Great. And we will be sharing the slides, and I believe Gail.
Anna?
Yep. Yeah, we can, I'll work with the team to make sure we can share that.
Yes, it just popped up in chat. Rosemary Cervone asked, can you share the blue form? And I think you just answered that question.
Yep, we can find a way to get that on the website, no problem.
Okay, and once again, if anyone has any questions over the phone, it's #6. I think we have just a couple minutes left if you wanted to ask something over the telephone, #6.
If there are no more questions, I have put up our last slide, which gives you information on our safe transition state leads in each of our 6 states. Please feel free to contact them to find out further information and also about the work that we do. And we'd love to hear from you always about your best practices. So feel free to contact any one of us. And we thank you so much for joining us today. One last call for questions. Otherwise, we will sign off and thank you again to our Butler colleagues for sharing so willingly and beautifully. Thank you.
And one last thing before we hang up, when you close out of the webinar, the evaluation will automatically pop up on your computer. If you could please fill that out, we would greatly appreciate it. Your feedback is very important. If you don't have time today to fill it out right now, or you're currently sharing a computer with someone else, we'll also be sending you an email tomorrow morning with a link to the evaluation. That email will also contain the direct link to the event page on our website. This web page has the PowerPoint presentation from today's session, as Gail mentioned. Also within the next couple of business days, the recording from today's session, as well as the transcript, will be added to this web page as well, and available for you to download and share with your colleagues. And lastly, please save the date for our next webinar session, which will take place on September 22nd. Details will be shared with you in late August. So we thank you again for attending today, and we hope you all have a great day.